Don't be surprised if you find yourself needing surgery and your surgeon has an unexpected assistant, a robot. But it won't be R2-D2 or C-3PO from Star Wars. Instead, the modern medical robot is a high-tech tool that surgeons use to perform sensitive tasks in hard-to-reach places. In today's podcast, Dr. Vivian Wu, a head and neck surgeon at Pacific Neuroscience Institute, takes us into the new world of robotic surgeries. Dr. Wu will also tell us about some new tests that can show how successful someone's cancer treatment has been without the need for invasive biopsies. She'll also tell us about how to prevent and treat human papillomavirus, or HPV, which has started showing up in people's mouths in greater numbers. Dr. Wu also talks about the important role a care village plays in patients' treatment and recovery. Hi, I'm Dan Faust. I'm the host of the Think Neuro podcast at the Pacific Neuroscience Institute. And today, our special guest is Dr. Vivian Wu. Welcome, Dr. Wu, to the podcast, and ask you to please tell us about what you do at PNI.
Great. Hi. Thank you for having me. I'm Vivian Wu. I'm a head and neck surgeon for Pacific Neuroscience Institute. What does it mean to be a head and neck surgeon? Well, I'm fellowship trained in head and neck surgical oncology, so my focus really is on cancers of the head and neck.
One of the things I wanted to talk to you about today, you've used robots in your surgical practice, and I think that is a fascinating field, and I'm very interested to hear how you got started with that, how commonplace that is, and just how it works for the layperson to think, if you find out that their surgeon is using a robot, what does that mean? So when you first encountered robots,
Sure.
was that already fairly commonplace when you started your training?
No. So I started, I'm dating myself here, but I started training in 2004. Okay. So in 2004, there was definitely no robot. I'm sure they had built it and they were prototyping it, whatever. But by the time I finished, I did 7 years as opposed to the regular 5 because I spent a couple years in the lab. But by the time I finished, we were certainly doing, not more than a handful, maybe 5 handfuls, whatever that adds up to, of cases using the robot. And so, but really the trajectory of use of the robot was pretty quick after that. Really the team that sort of studied it and really got it into our field was out of UPenn, Dr. Gregory Weinstein and Bert O'Malley, who really kind of, like I said, we're doing the most cases and sort of at all the meetings talking to us about it. And, until, you get the results of like what they're doing, they publish a couple of papers. Hey, we've been doing this for 2 years now and look at what we do. Look at how amazing this is. And everybody was like, wow, this is pretty cool, really, really fun. So what does it mean in the OR? Like, what does it mean to use a robot? So we use it to access areas that are very hard to access surgically. And what does that mean for the head and neck? Well, if you can imagine, you can do surgery on your tongue or the front of your mouth or even your cheek pretty easily just by looking in your mouth. But just imagine, if you're opening your mouth and your tumor is way in the back of your mouth, it's kind of a deep, dark hole back there. And in fact, many of these tumors are not just in the very back of the mouth, but they're around the corner. So like if you look in the back and you drop 9 degrees down, like that's kind of where a lot of these tumors are. And so how do you even operate on something you can't see? And so once the robot came around, it allowed us with a camera to visualize that area. And not only do you need a camera to visualize, because we had cameras before, but they weren't really linked up to instruments that you could actually utilize back there to do things that a surgeon's hand could do, right? So you need the movement and the sort of, I think they call it wristing of the instruments to be able to really get into little nooks and crannies and corners and cut these things out. The robot is a machine that allows you to see with a camera and then also has instruments. And it's on a console I'm not even sure if you call it a console. It's on the robot, but the console is separate and the surgeon is controlling it from that console. So we don't even have to scrub. You have a mask and a hat on, but other than that, you don't need gloves or anything to sit at the console and control the wristed arms and the camera to actually see what you need to see.
Lately, we've been getting used to the notion in our daily lives that robots, or at least some kind of computer-operated device, are capable of outperforming humans in certain tasks. Maybe it's a Roomba, saving you the trouble of reaching under the sofa to vacuum. Maybe it's a self-driving car, equipped with all kinds of sensors that can deliver you safely to your destination without anyone even touching the steering wheel. Some of those advances are certainly helping to inform the development of the robots used in operating rooms. But Dr. Wu is very clear. It's not an autonomous robot or artificial intelligence that's operating on patients. The robot, in this case, is merely a tool that the surgeon controls the entire time.
Every single move that you make, you're looking for the next blood vessel, or you're maybe looking for a nerve. And so these are the things, like, I can't really program that, right? I mean, I guess maybe someday you could, but the answer is like, you need the eyes and the quick, the quick movements and experience of the surgeon to be able to say, hey, listen, I cauterize that, or we got to move to a different area. We got to move to a different part of the surgery so that we could avoid it, or whatever it is that needs to happen. So yes, 100% controlled by us. And has no thoughts of its own.
In recent decades, surgery has evolved dramatically. New tools enable surgeons to extract tumors in the most minimally invasive way possible, rather than leaving large scars. Cameras and scopes have been among the most significant of those tools, and the new robotic equipment is bringing the images from inside the body more clearly than ever before.
It is high definition. Whereas, again, if you can imagine, I'm just looking in the mouth with my eyes that need eyeglasses, like that is in no way, shape, or form like high def visualization. So the ability to see the structures you're encountering in surgery is just so much better with this tool, because the camera is just amazing. And the camera is not a straight line camera, again, because it's easier to make, like a straight line instrument, like a camera that looks straight ahead in one field of view. This camera can, we put it in something called a cobra pose at times. It's got like this kind of angle, and then you can like swoop it down to see what you need to see. So you really have a lot of flexibility on where you're looking with this camera that can just move with you and go where you need it to go. So it's very cool.
And the camera is there with the tools that you then manipulate.
Yeah, they're actually side by side, but of course, you can have the camera here and you can have your instruments coming around this way and the third instrument coming up from here. There's just all sorts of configurations that you can do it. But yeah, you move the instruments and the cameras sort of together.
And then the instruments just can go in, and do you actually remove a tumor that way?
Correct. Set your camera to where you can see the best you can see. You leave that in place so that, you got your view, and then you bring in your armed instruments we do some retraction, which means holding the tissue and pulling it to the side. And then this arm might be the cutting arm, which is sort of your hot knife, which is going through the tissue and cauterizing at the same time. So it's pretty amazing, the capabilities we can do now. And the fact that we've got 3 arms or 3 different instruments that we can use in there really makes it better.
To visualize how Dr. Wu and her colleagues use these robots, it helps to understand how the devices reach the areas where the surgeons need to work. In the recent past, a surgeon would need to run 3 stiff tubes down someone's throat, using what Dr. Wu called the 3 ports. These tubes, known as trocars, took up valuable space in the narrow region, which presented a challenge to the surgeon. The robotic device, on the other hand, is able to put 4 instruments, including the camera and the device that will remove the tumor, into a single trocar.
there's other robots that are 3 ports. So the robot we're talking about, and I don't know if we explain this, is a single port robot, which means there's one sort of trocar and all 4 instruments come through that and then deploy the way they need to after. Previously, we would have 3 different trocars. All 3 of them would have to come into the mouth, and then you would have 1 instrument in each trocar. And so it just takes up a lot more space that way. So the single port robot really, I think, was a tool that almost was created for the head and neck. We have such little space here, but certainly my urology colleagues, my gyn colleagues, actually lots of people are using the single port robot now. So,
and it sounds like it's especially useful in a head and the neck where it's such a small space that you're working with.
yeah, anywhere it's a small space, it's ideal.
It sounds like the robots just, of course, continue to evolve as technology keeps getting more capable.
Just like your phone, right? There's so many fun things that you can do on it that I have no idea how to do. And I'm still learning on the robot too. There's a lot of functionality on there that that can help the surgeon make it easier. You could preset things, and so it's pretty cool, all the new functionality that the company can provide. I appreciate their efforts, and what's really great about it is I do think that they're taking feedback from the surgeons and saying, listen, how can we make it better for them? And
let's talk a little bit about the types of tumors that you're taking out, that you're using the robots. And I think a lot of these turn out to be related to the HPV virus.
yeah.
And so tell me about that virus. It's a sexually transmitted virus, but it's somehow implicated in head and neck tumors.
I mean, the HPV virus is everywhere. And I think everybody must have heard of this by now. And if it's not because of marketing and patient education from the head and neck side of things, it's certainly from the cervical cancer side of things. I think, to be honest, that's probably how most people know of the HPV vaccine causing cancers, is through the efforts of the cervical cancer community. Head and neck cancers, and most of them are in the tonsil. So the tonsils that you get as a kid, and also what's called the base of tongue, which is, again, your tongue sits out like this, but there's the backside that you can't see. The back here is what's called the base of tongue. And those are what we call lingual tonsils. It's actually kind of the same exact tissue as the tonsils that you get out as a kid, but they live on the back of the tongue. So these HPV cancers are frequently found in those regions. And I would say 60 to 80% of our tonsil base of tongue cancers are HPV related. HPV is it's a sexually transmitted disease, but it is really endemic in our society. Like 80% of us will actually get this virus and be infected with it. And majority of us, up to probably upwards of 90%, clear it. Okay. And so the question is, well, who doesn't clear it? And the virus does sort of park itself, in the cells and kind of sits there for a while. The latency period of this is, we think, anywhere from 10 to 20 years. You could have it, you don't even know it. And you could have it, and then in 18 months, in 12 months, you could not have it again. You could clear it. We know that as the natural history of how this virus works.
But during that time, you could be spreading it to other people.
Well, it's possible. There's got to be a lot that comes together for that to happen. Probably excoriations or cuts on the surfaces of that touch and that type of thing. There's some thought that even really deep kissing, though, can transmit. So I don't want people to be so worried about things like this when most of us clear it. But that's also, and I'm going to just throw it out there, we've got a vaccine now, so a way to potentially prevent you from having to experience any kind of like HPV related cancer experience.
And both men and women should get that vaccine.
Absolutely. Head and neck cancers, tonsil and base of tongue, is actually majority found in men. The numbers range from 3 to 1 males to females to 8 to 1 males to females. So either way, males certainly get this more than females. And so yes, absolutely, boys and girls should be getting this vaccine.
And then I think you were going to talk a little bit about how that does make its way into the mouth and throat.
Yeah, there was a paper that indicated that those who sort of had early sexual debut or had more sexual partners, whether it be the traditional way or through oral sex, that type of thing. The more partners they have, the earlier they debut, the more likely they were to be infected, and certainly the more chances you are of infection, the more chances you have of actually developing the cancer. So, again, if you're one of the lucky ones who clear it, great. That's exactly how things should work. But the fact of the matter is not everybody clears it, and we just don't know who those people are.
It's also important to note that HPV can also stem from an individual's use of tobacco and alcohol. Any oncologist or surgeon who removes cancerous tumors will warn you about the risk factors in an effort to prevent the cancer in the first place. Dr. Wu is no exception. Here, she tells us about how few pack years of smoking can lead to one of these cancers. If you're not familiar with the term, the American Cancer Society says a pack year is the equivalent of smoking 1 pack, or about 20 cigarettes, per day for a year. For example, a person could have a 20-pack year history by smoking 1 pack a day for 20 years, or by smoking 2 packs a day for 10 years.
Many of our head and neck HPV patients also have a history of smoking and drinking too. And, well, how much smoking and how much drinking? Well, the answer is as well, I think, yes, we have papers that kind of dictate, okay, it's going to be less than 5 pack years, which means like a measurement of how much smoking you've done, right? So yes, there's papers that'll use sort of 5 pack years or like this kind of pack years, whatever. How much alcohol, to be honest, I'm sure there's a number there. It was like, what is too much, right? But majority of our HPV patients also have a fair amount of that smoking, drinking history in there too. So it's a bit of a mixed picture it's a bit of a mixed picture as like, well, what's actually causing things? Let me back up a little bit. Let me include this part, which is that HPV related tumors in general do very well. And our traditional head and neck cancer patients, which are the smokers and the drinkers, right? You kind of think of that sort of Marlboro Man image. That's kind of my typical head and neck patient. That's like when I was training, that was really the group of patients that we knew, salt of the earth types that would potentially develop these kinds of things. It's because of this HPV thing, it's definitely shifted. HPV is everywhere. Okay. Anybody can get the virus and then potentially develop these cancers. And so, we know that, but we know that patients who are HPV only, non-smoker, non-drinker, they do very well. Their cancers are, to be honest, very easily cured. And in fact, in the data sets that we look at, okay, if you're HPV only, that's the only reason why you have cancer, really, really, really great cure rate. If you're HPV negative, smoker and drinker, your survival is a little bit lower. If you're got a combination of HPV plus smoking and drinking, it's kind of like it meets in the middle. Okay, so smoking and drinking history does sort of negate some of the like amazing cure rates of like HPV alone, but they still do very well.
You were talking at one point about something called the circulating tumor DNA testing. Can you tell me a little bit more about that?
Yeah, so circulating tumor DNA, I think out there's words like liquid biopsies, ways to kind of identify tumors in an easier way than actually doing a physical tissue biopsy, which requires needles. I mean, like needles that go into not just your veins. I think everybody is familiar with needles going into veins, and some of us are very uncomfortable with even that concept, but that concept is out there, right? Okay, sometimes we need to just draw blood. Okay, if you need to get a biopsy for a tumor, you need to stick the needle into the tumor, which can sometimes be in weird places, right? Whether it be your prostate or, here on the face or in the neck. So very uncomfortable, and it's just invasive, okay? Invasive in a way that is different for most people. The circulating tumor DNA is really a hot new topic throughout all of oncology. Hey, can we somehow draw blood and identify cancer, like gene products of a cancer in the blood? And so in the head and neck as well, we've got at least one very good test that we can do that is now FDA approved, and Medicare covers this, which is looking for circulating tumor DNA, which means it's the HPV tumors. sheds off products in the blood. And if you have tumor in your body, there's a certain level in the blood that'll be in the blood. And then this test will be able to identify that with a blood draw. There's one company that's doing, there's probably more than one company that's doing it. There's also many, many academic institutions that are trying to develop their own tests. There's also folks trying to identify the same sort of gene products even in your urine, even easier, right? Just pee in a cup. Like that would be great. If you could just maybe spit into a cup too, that would be great. So there's all different ways to kind of do sort of liquid biopsies, but the urine part and the spitting into a cup part hasn't necessarily quite come to fruition in the head and neck, although the urine's getting there. I think we probably will get there, maybe 5-10 years, maybe less, depending on who you talk to.
Well, so I'm kind of curious, how does this work? Like you get a patient to come in and then you suspect they have a tumor somewhere in the head and neck region, and then you would order a circulating tumor DNA test.
Well, so right now we're not using it for diagnosis. Really, right now, it's mostly being used to surveil patients. So patients who are finished with their cancer treatment, the way we traditionally would watch them is a physical exam. So a clinical exam, you come in, so I can take a feel around, take a look around, use my scopes and look around, and see if there's anything unusual. On top of that, we would do imaging. So CT scans or PET scans to say, hey, is there anything new or weird that's, that shouldn't be there? And again, this is after your treatment's done, where you should have nothing, no tumors, no strange and unusual nodules left. But this test right now is being used more in this setting where it's another adjunct way to monitor a patient. Hey, let's also draw your blood. And if your circulating tumor DNA is 0, then we can feel pretty comfortable you don't have any kind of recurrence. And so that's really where we're using it now. For the head and neck, we're still doing the needle biopsies or the actual biopsies in the operating room to diagnose these patients.
Okay, yeah, I was wondering because I was trying to figure out how does this take the place of a biopsy in practice.
People who are trying to develop liquid biopsies, their goal is not only to diagnose, but to do prognostication. How bad is this tumor? To also do surveillance and monitoring, to, also test, hey, how is this? You're mid-treatment. You could draw blood and maybe see how the patient's doing, and maybe switch gears mid-treatment if it's not, if things are going the direction you want it to. So these are all sort of pie in the sky. Hopefully we can get there. But what people definitely are doing now, at least for the head and neck and for surveillance, is using it post-treatment.
Does the test tell you what type of cancer?
Our ctDNA test is very specific for HPV-related head and neck cancer. It's not being used for any other cancer type. So, I mean, this is a very focused, test that I'm talking about, the circulating tumor DNA for HPV. Can the cervical cancer folks use this test? I don't think they are, because I think it is still very specific to the tonsil, but it's all proprietary.
But it's just so interesting that the blood test can tell not just that there's cancer, but what type of cancer.
That would be very cool. I mean, you're going to have different gene signatures in your blood, right? The genetics of it will be different. And so, that would be a whole nother podcast. And I think very interesting to talk to somebody in industry who's working on that type of thing, or even academics who's working on that type of thing.
That leads into the treatment, because I think, and if it does show up again, you need to make some decisions.
Even with these incredible advances in robotic surgery and circulating tumor DNA testing, sometimes there's no clear-cut answer to the question of what the best treatment option is for an individual patient. Pacific Neuroscience Institute calls on all of its expertise in these situations, convening a team of experts in different areas to analyze the various options available. For instance, a cancer could be treated with surgery, radiation, chemotherapy, or some combination of the three. Or maybe the best thing in certain situations is to wait and watch. PNI's multidisciplinary team takes every variable into account in order to find the best course of action for the patient.
I'll just kind of talk about head and neck cancers in general. Like, we see patients who have certainly tonsil and base of tongue and HPV related, but also we see patients who have maybe a voice box cancer or a actual tongue cancer or a jaw cancer. So, In the head and neck world, the oncology teams work very close together. Who are those? It's the surgical oncologist like me. There's the medical oncologist and the radiation oncologist, just like you mentioned. And my job as the surgical oncologist really to talk to them about, hey, this is what we can do for you surgically. Are you a good candidate for a surgery? Is this going to make you too debilitated to even think about surgery? And maybe we should switch gears and talk more about treating this with radiation and chemo. And of course, the radiation oncologist will go over their radiation plans and sort of their outcomes with what they use. And of course, our medical oncologist, same thing. I try to, when each patient comes in, really lay out their different options. There's some patients who really, they could have anything done. Like we could do surgery and radiation, or you could do chemo and radiation. I'll never touch you. Like there's all these different ways to approach for some patients, like early stage cancers, you got lots of different options, right? And so sometimes the hard decision is thrown back at the patient. Hey, like, what do you want me to do? And they're like, well, what do you think, doc? And so those are great cases where we can have a multidisciplinary discussion where sometimes we'll have the surgeon talk first, and then the patient goes to just downstairs maybe and talks to the radiation oncologist so that they kind of hear the whole gamut of what the options are, and then can make a decision. And if they need help making a decision, then what we actually have once a month and hopefully twice a month soon, a head and neck tumor board where we discuss all of these cases. So of course our oncology team's there, but we have our speech language pathologist there, our nutritionist there, all of our supportive oncology is there to kind of discuss this patient has a great family at home that can help, and so might not need as much, well, they'll always still need things, but just not as much like sort of social work assistance, or they have nobody at home and they're going to need extra care. So anyway, we have a really sort of holistic sort of discussion about a patient, like what are their needs, not just the oncologic and sort of cancer curing needs, but also like how do we make sure that their life and their quality of life is just as good afterwards as before. And so that multidisciplinary discussion is very key, I think, to honing in on the best recommendation for treatment and management of these patients.
It must be so comforting to think like there's all these people talking about your case, and that everybody can get more or less on the same page, that it's not just one meeting or a bunch of separate conversations, but that kind of working together.
It's comforting, I think, for the patient, but it's sometimes comforting also for us as providers, like, okay, everybody agrees with me. It feels good when like, okay, everybody agrees with my plan. But also, hey, I'm always open to, discussions in which the management plan really takes into account that patient and how they're going to do afterwards. And so that's really where we need so many brains together to be like, listen, everybody's got different experiences and sort of sees different aspects of this cancer. And so, how do we put that all together and really try and understand the patient before we present them in tumor board, understand their wants and their needs and like what they actually have at home to support them and help them, and then come out the other end with what we think is probably best for them. So yes, I think that every patient deserves a multidisciplinary discussion. Every cancer patient deserves that. So comforting for the patient and for the providers who, hopefully, like I said, we're all in agreement about this.
Those multidisciplinary discussions frequently focus on the effort to not over-medicate the patient. Tools such as radiation and chemotherapy can have a big effect on people's bodies, and the doctors and other members of the patient's team don't want them to go through any more of an ordeal than necessary. Lowering the doses of these powerful tools is known as de-escalation.
HPV-related cancers, they are on the rise, but the good news is they do very well. What we're working on is trying to figure out, because they do so well, can we de-escalate care for these patients? Can we give a little less radiation? Can we cut out chemo altogether? Are there ways to, again, de-escalate the care for patients who are HPV positive? And there's been, a fair amount of studies out there, even sort of national clinical trials looking at it. I don't think that the practice change where people are, if you're HPV positive, we're going to give you a much lower dose, where across the country people are doing that. We're not there yet. Okay, so it hasn't become a gold standard where we're de-escalating care for these patients. I think we'll probably get there. We'll probably get there soon. This is one in which, hey, we can kind of cater to the disease, right? Like we know that you're going to do really well. Maybe we don't need to give you 7 weeks of radiation. Maybe we can get away with just 5. That's what we're thinking about in our world. And I hope to get there because, we always want to do as much as we can to cure the cancer, but not more.
A cancer diagnosis is a life-changing event. It often rocks people's worlds. That's why Dr. Wu says people undergoing cancer treatment are never alone. Patients typically have a team, if not more than one team. They have one team at a place like PNI, comprised of medical professionals, including doctors, nurses, social workers, nutritionists, speech pathologists, support staff, and others who can provide treatment and guide them through the necessary steps. Their other team is one of family and friends who provide a vital role in a person's cancer journey.
Once you have a cancer diagnosis, I really do think you need the village to help take care of you. So I don't even mean just the home on the home front, but your doctors and the supportive oncology team, like that is just critically important to support you through what we put you through, but I do tell patients, hey, we're here for you, we have our village for you, but you need to go home and sort of find your people that can sort of walk you through and hold your hand while you go through this, because as much as we like to do that, we're not here 24/7, although we tried our best to really be accessible. I had a patient the other day who she said, there's really nobody here, but my daughter's in Seattle. And I said, listen, go to Seattle. I can get you linked up with the people that I know who are excellent in Seattle. So please go there if you have a daughter who will be with you throughout this treatment, because that's really so important.
That's really interesting. Yeah, it's a good reminder of people always think, oh, I want to go to where the best doctor maybe or the best care, but you can find good care somewhere if you can find that support network as well. It's about putting the whole package together.
I'm always looking for people to join our village of support network and care providers for patients. And that, for the head and neck, really, that means not only, and I already mentioned speech language pathology and nutrition, that type of thing, but, hey, I'm looking for dentists out there who are willing to partner and work with us to identify early lesions. And I'm always happy to help consult on anything that looks funny in the mouth, if people don't really know what they're looking at.
That's a fascinating subject to me too, because I've talked to people in the dental field and the dental education field, and they feel often like they're kind of relegated to a second class status. It's not always covered by insurance in the same way that a lot of other health things are, and yet it is. So, what's going on in your mouth is so vitally important to the rest of your health.
Yeah, I mean, like nobody sees a head and neck surgeon on a regular basis, right? But you go see your dentist every 6 months, and they know your mouth the best. And to be honest, it's like the dental hygienists really know the mouth the best, right? So they're in there like, for a good 30 minutes or so, looking around, doing the videos, doing the picture taking, to partner with these people to say, listen, I'm here for that community, and hopefully vice versa, that they can identify early lesions and we can address them early. That's kind of really key. Another part of my practice is skin cancer, right? And in skin cancer, I've had several patients come into me because their hairdressers found something on their scalp. And it's like, yeah, like who else is looking up there on a regular basis but your hairdresser? So, I mean, kudos to those hairdressers to be like, listen, this should be addressed. Like this is not normal. They know what a scalp looks like, I was talking recently to like a massage therapist, because we got like lumps and bumps that grow on the neck, right, or anywhere really, but like a massage therapist, like, yeah, they're like massaging, like, oh, what's this weird thing? Like, hey, send those patients so that they, or tell them, hey, this is something unusual, you should probably have it looked at. So there's just so much in the community that I think that can help to be alert and aware of things that if they think it's unusual, it probably is, and just to have somebody look at it. So there's, like I said, there's a lot of soldiers out there that can help identify things and send them to the right place. So,
well, Dr. Wu, thank you so much for your time today. Really a pleasure to talk to you, and best of luck.
Thank you. It was great talking to you, and thanks for putting this very important topic out there. It's my world and I love it. And I really appreciate being able to share it.
For a patient experiencing a cancer diagnosis, There are often a number of things going through that patient's mind. Will I be okay? What will happen to me? What if I need surgery? For the patient, their world has just been turned upside down. That's where Dr. Wu and the wonderful team at PNI come in. They welcome the patient into the clinic with the commitment of providing the best care possible. This is Dan Faust for the Think Neuro podcast. Join us next time for more in-depth episodes from Pacific Neuroscience Institute.